My name is Marc Evans. I'm a diabetologist from Cardiff in the UK, where we work quite a lot on looking at health economic evaluations, cost effectiveness studies, and various other components of value assessments of technologies in diabetes and other disease areas. So the background to this, I think, is a follow-on from Simon's earlier question relating to the potential limitations of the UK PDS risk equations when it comes to how we estimate value in type 2 diabetes. Now, the setting for this is the SUSTAIN-6 study, which is one of the numerous cardiovascular outcome trials that have been published and presented and are ongoing. And we've seen data from such studies as EMPA-REG, CANVAS, etc., that have shown potential outcome benefit, also seen in the LEADER study. And one of the questions that persists is whether or not these outcome benefits are attributable purely to the change in risk factors, and whether or not the UK PDS risk equations actually work or are fit for purpose, set in the context of a treatment era where you have drug effects that are very different from the drugs that were used in the UK PDS study. So as a first step to try to look at this, effectively what we did was run a revalidation exercise or a recalibration exercise using the initial UK PDS 68 and the updated 82 equations to look at their performance in the context of predicting the observed stroke outcome benefit that was seen in the SUSTAIN-6 study. Now, the SUSTAIN-6 study, for those of you that aren't necessarily aware, was a cardiovascular safety study predicated on an upper 95% confidence threshold of 1.8 with semaglutide versus standard of care run over a 2-year period that demonstrated a 26% relative risk reduction in stroke. So effectively what we did was run the stroke risk reduction as a function of the risk factor changes through UK PDS 68 and 82 equations, and also look just at whether or not the risk factor changes per se could predict that 2-year treatment effect, and then run that over a projected 50-year time horizon to look at quality gains as a function of those particular observed outcomes. And effectively what we saw was that the 68 and 82 risk equations were able to predict 64 and 50% respectively of the observed outcome benefit seen with semaglutide in the SUSTAIN-6 study. And when you ran that in terms of quality gains with once weekly semaglutide versus standard of care as seen in the observed versus the predicted model, you saw a greater quality gain both from UK PDS 68 and 82 simulations in the observed semaglutide data. So what this effectively demonstrated was that we need to think beyond simple risk factor modulation as these are reflected in the long-term outcomes, and think about trying to figure out a way to include drug-specific effects in terms of the modelling exercise. There are a variety of limitations to this. Obviously, time horizon here is only a 2-year treatment effect, and we are assuming that that 2-year treatment effect persists in terms of risk reduction, which it's bound to. So if you're down at a 26% lower risk reduction, even if you discontinue treatment at 2 years, you're starting from a different baseline to where you were in placebo. So that's something to consider. So in essence, what we're trying to do here is move towards a new approach to evaluating cost effectiveness, including cardiovascular outcome data to inform model simulations going forward.